Good morning, everybody. It's Monday morning and it's 10 o'clock. So the majority of stuff that I've got this week is from the discussion boards, and the stuff that is on the discussion boards is more or less exclusively from Saudi Arabia. So thank you very much for that, Saudi Arabia. I'm not putting pressure on you face-to-face crowd, because everything that you need to say to me, you can say to me in class, so that's not really a problem. But I'm glad that everybody enjoyed Dave's presentation last week. He is really top class, Dave. For those of you who are in Saudi Arabia, Dave Thornton, as well as being the principal pharmacist in Aintree Hospital here in Liverpool, he is also the leader of the Pharmacists Union in the UK. So he's a specialist in cardiovascular medication. He's president of the union, and he does a really good, and he does it every time as well. He's real reliable, Dave is. So Saudi Arabia, it was thanks to the face-to-face students that I put that presentation up online, because they said that they were so impressed by him that they would like to have access to it at home. Pauline, nice one, Pauline. So it was thanks to them that I put it up. That's what I'm struggling to say here. It was thanks to them that I put it up, because they were impressed too. So what have I got this week? This week's stuff was about medications, and it is rather a large session. The online thing that I did with Chris Nicholson is rather a large session, because there's rather a lot to say, isn't it? And there's a few things that have been put up on the discussion board there. Delphine, for instance, addresses very quickly the issue of the complications associated with the use of ACE inhibitors, which is dry cough. Now, that's what the textbooks call it. The textbooks call it a dry and irritating cough. But I take the position that I'm in now. I take ACE inhibitors. I'm at the right age, I've got the right medical history. I take ACE inhibitors, and I've got to tell you that I wouldn't describe it as a dry, irritating cough. I don't know what it's like for other people, but I know what a dry, irritating cough feels like. It's kind of up there in your throat, and you feel as though it's an itch, or the irritating cough that I get, certainly and I've located it to the ACE inhibitor, comes on roughly a couple of hours after I've had the tablet, and it's only 2.5 in the morning, 2.5 in the evening. That's what I take. And about an hour and a half, 2 hours after I've taken the ACE inhibitor, I start to get the sensation that there's something crawling in my trachea. That's the feeling. Now, it's a non-productive cough, and it's dry in the sense that you're not actually coughing anything up. But it's not a dry cough in the sense that we're all familiar with a dry cough when you have, a late effect of a cold or something like that. It doesn't feel like that. It feels like something's crawling around, right? It is the most... So what it's like for people who are on 10 milligrams in the morning and in the evening, I can't even imagine. 2.5 is bad enough. And I remember when I first started on these ACE inhibitors, I said to Dave Thornton, I haven't had any cough yet, and it was about 8 weeks, 12 weeks in. I said, I haven't noticed any side effect of a dry, irritating cough. And Dave was sat opposite me, and he said, yeah, not yet, you haven't. And that's kind of the way it worked out, really. I started to be conscious of the fact that soon after the taking of this medication, this started to come on. Not enough to stop me taking it, I've got to say that. Not enough even to make me think about stopping taking it, but just, not the most pleasant thing. Now, so thank you, Delphine. Next one, Rachel. Rachel talks about one of the big problems with medicating, particularly the older patients, is diuretics, and that you sometimes get a drop off in compliance from the with taking medications, because people don't like taking diuretics and feeling as though when they go out they're going to have to find the toilet all the time. And this is more than a complication, and it's more than non-compliance, isn't it? This is a disabling and isolating aspect of the treatment of heart failure. Would you go out? Would you seriously go out if you've taken a medication that you feared might make you wee yourself? You'd stay in. I'd stay in until the worst was over. And the risk of that is that these people don't mix in the community in the way that they used to, become isolated, constantly being lectured by doctors and nurses on the importance of taking their medication. And yet, if they go out, they run a risk of being humiliated. Not nice. And here's something else on the question of diuretics. I heard a report on the radio, which I don't doubt, many months ago now, that that one of the medications which are most associated with serious complications. So I'm thinking, hello, this is probably chemotherapy, or it's probably some really exotic drugs. No. One of the most complex, one of the most common drugs for creating complications in patients is diuretics, and the reason being is that the patient may already be a bit dry, take a diuretic, they go to the toilet and lose a load more fluid, and now they're hypovolemic, so when they stand up to put their coat on to go to church, now they are hypovolemic, so they feel all lightheaded, fall over, cracked hip. Oh yeah, of course that must happen all the time. Yeah, another complication and not a complication that you would think of, is it? With diuretics. I mean, you'd think of low potassium, you'd think of or dehydration, but you wouldn't think of fractured hip being a complication of furosemide. So yeah, side effects of furosemide. Delphine, good question. Not one that I had an answer on, and I wasn't in class, so I couldn't ask Dave what his opinion was on the medical treatment of heart failure with preserved ejection fraction. So what I've done is I've found you a paper there, Delphine, and I've put that on the discussion board so you can take a look at yourself. Looks a bit complicated to me, but it's from the European Heart Journal, 2011, so it's kosher. And for those of you who are on the face-to-face course, well, wouldn't do you any harm taking a look at that as well. So I'm already getting suggestions for essays. Right, now I'm hoping that I've encouraged you enough to use RefWorks, but I want to say something else to you now. If you have a draft, don't send it to me by email. Put it on Turnitin. You will find Turnitin on the module assessment button on the left-hand side of the page when you go into Blackboard. The reason why I'm telling you to do that is you should get practice in how to submit your work through Turnitin. The last thing I want is for somebody to ring me up on submission day saying that they're confused about how to hand work in. You can put your work in however many times you want onto Turnitin. Each time you put your work in, it will erase the previous version. So you can go in as many times as you want and it will erase the previous version until 4 o'clock on the 16th of December. And at that point, you can't erase it. Yeah, but get practice now. So put a draft in, turn it in, and then email me notification to say you've put a draft in, turn it in, would I please take a look? And I will. So there you are. Nothing else, I don't believe there is. So good to see you all, and keep up the good work, Saudi Arabia. Bye now.